And now, without further ado, I would like to introduce Dr. Bisola Onajin-Obembe. Dr. Obembe is a consultant anesthesiologist and assistant professor of anesthesia at the University of Port Harcourt, Rivers State, Nigeria. Dr. Obembe also practices and teaches pediatric anesthesia, as well as anesthesia for maxillofacial and ear, nose, and throat surgeries, and she has publications in these areas. She has developed interest in team building, leadership, strategy, and organizational change management, of which she plays roles within and outside of Nigeria. Also, Dr. Lauri Romanzi. Dr. Lauri Romanzi is an OBGYN with 15 years global health experience. She has collaborated with colleagues, funders, and other stakeholders through Africa and South Asia, ranging from policy to clinical practice levels. I will invite you here.
It's a pleasure to be here today. I am replacing Lauri, Vice President of Innovations at the American College of Obstetrics and Gynecology, who unfortunately had a travel issue and will arrive too late to be here. I think it's safe to say, preaching to the choir, women's health is undervalued and also far too often suffers from politicized agendas that create more roadblocks. And we won't meet the Sustainable Development Goals without fully empowering women's health care. Along with that, we have to empower women's leadership in the healthcare sector. Currently, I serve as a director of a USAID-funded Fistula project at EngenderHealth. Now, fistula was eradicated in the global north in the early 1900s, a good 40 years before antibiotics were available, to give you a perspective of that time. And still, today, obstetric fistula is a threat for every single pregnant woman in the majority of the world. This is wrong. This is inequity at its worst and most egregious. And the way that you prevent fistula is with safe, affordable, accessible, high-quality cesarean section. So every day in this role, I'm frustrated by the persistence of global health inequity as it affects women. I can also say in my career, I've seen a massive shift. When I was finishing medical school in OBGYN, it was still very much a man's world. And at that time, it was around 20% of OBGYN residents were women. In my career, that has gone to the complete and other end of the spectrum. And now we have, I think it's 82% of residents in the United States OBGYN training programs are women, and they're top of the class women. These are very competitive, top of the medical school class applicants. Still, we have a dearth of leadership in academia. We have a dearth of leadership in industry. And we also, actually, it's such an intense shift that just last month, our national public radio published a piece saying, maybe we need more men in OBGYN. I said, maybe we do, but let's let women come up and take those positions of power, because who better to understand OBGYN than women? And it affects how you train, it affects how you implement programs. And while men who are champions of women's health are some of my favorite people in the world, it still requires women in leadership roles. One of my favorite things about working overseas is that somehow that fades away. I don't know if it's because I'm from the US and I'm going into low and middle income settings, but my gender ceases to be an issue. I find that really quite a lot of fun. But I know when I work in Nigeria, I also see already a lot of women in the healthcare sector, and they seem to be in positions of academic power. But I'm wondering what your experience has been, Bisola.
Yeah, thank you. My experience has been a little bit different because, in Nigeria, all the men, the male doctors and specialists left for Saudi Arabia, left for greener pastures, And so we have the women staying back, probably because they were married and they didn't have the kind of opportunity to leave the shores of Nigeria. So they were left behind to manage the crisis. Okay. And anesthesia, I'm an anesthesiologist, and anesthesia was not the priority career, you know, in Nigeria. You want to be seen, gynecologists, surgeons, and, you know, all the rest of it. Anesthesia, you're backstage. So it was left to the women. It was more like a feminist, you know, thing. And so the women were the ones to pick up anesthesia, stayed at home and developed it. So that anesthesia in Nigeria became a feminine career. And it's until recently, you know, with the intensive care, the gadgets, the technology, the men started coming into anesthesia. So it was a little bit different. But then it was, we were not respected like our male colleagues, you know, until the men started coming into anesthesia and seeing. Initially, you think, oh, just put a face mask, put chloroform, and the patient will go to sleep. It's no big deal. And when I got into anesthesia myself, I thought, oh, it's no big deal. Just put the chloroform. Then I saw, or whatever it is, halothane. But then I saw that I had to see the patients, review, inspection, palpation, percussion, auscultation. I had to look at the physics of, you know, the anesthetic machines, the laws. I had to look at drugs, intravenous drugs, gas laws, you know, Boy's laws and all the rest of it, the gadgets, the physiology, the anatomy, you know. So it's quite, it was a challenge, really. But then, because other women had gone ahead to excel in it, we decided to own it and excel in it. But now we're having both male and female come in, and then, you know, the nurses, just like the nurses, nurse anesthetist, he was like a feminine thing. But we all know that it's not a feminine thing. Now we have both sides coming into it. You know.
It's true. Have you ever had the experience of the, oh, thank you. And have you had patients or their families say, where's the doctor? Have you had that?
Yes, because the first time they see you, they think, oh,
yes.
well, you are a nurse, or, you know. But then they get to know the difference, because once I think it comes with a personal touch. You doing your review and explaining, getting the consent, then they get to respect you. Then your colleagues also get to respect you. Because I've seen situations where the surgeon comes and says, I want this done right now. And I say, oh, fine. You're going to have a beautiful surgery, but then can we guarantee the life of the patient? Because post-operatively, we may run into challenges. So it comes with working as a team, explaining. Where you don't have physicians to explain, then you have problems, because I want to do this case right now without optimizing the patient. So we need to, especially in a place like areas in Nigeria, you know, rural areas, we need to make sure that we have capacity for anesthesia, build up capacity where there is no capacity, as well as teach the team what it's all about.
Exactly, yeah. Nothing worse than having to say that surgery was a success, but the patient died, right?
Yeah.
So mentoring, I think we should talk a bit about mentoring, because I found that to be a real gap as I was coming up. I felt very much until maybe the last 5 years that I was making my own way, and mentoring of women by men or women, and mentoring between women is something I think women have a harder time being effective at. What do you think?
Traditionally, the medical profession has been that of the boss and the students, you know, or the learner, or, you know, you learn on the job. So it's been like that, but with time, it's been changing. For example, the program in Lagos University Teaching Hospital started with a woman who came from Canada, Professor Shirley Fleming, and she started this program and she mentored, people, and so that was how anesthesia developed in Lagos. So mentoring really is very important, but it gets to a point where it becomes a thing of, I'm the champion, I'm the big boss, and the kind of forget that you need to duplicate yourself. You need to have more, you need to teach more, you need to mentor others. You want to be the, I'm the big fish. And so a problem was created where you had lone workers, lone leaders, and then the crisis began. But now, I think we're realizing that there's a gap in mentorship, mentoring your colleagues, in winning residents, in getting new people into, I'm talking of anesthesia now, and sometimes other areas. So we need to, the leadership, letting people come, buying them over, winning them over right from medical school is becoming evident that we need to close up the gap and encourage more people to come into anesthesia. So it's really very important that we do that. Yeah.
One thing I've noticed in resource-constrained settings is that the best anesthesia services are reserved for the main operating theater. And the maternity, by necessity, needs its own theater so we can deal with obstetrics emergencies as they come up and not try to crowd the main operating theater. But anesthesia healthcare worker density is so constrained, it's much easier, I think, to deal with the main operating theater. And so you often see maternity underserved. We have many facilities that we work with through our project where the fistula surgeon is still putting in the spinal with no anesthesia monitoring whatsoever, not even a pulse oximeter. I know LifeBox is here somewhere. What's the situation in Nigeria? Is there an awareness of this or a plan for it?
With the World Federation of Society of Anesthesiologists working so hard to close the gap and raise awareness, because we have a World Anesthesia Day, and there's been a lot of reach out to other people to realize that this is an area where we need to train, where we need to reach out to the rural areas. Of course, I don't think an anesthesiologist, after training for 5 years, 6 years, will want to go to rural areas. So we do recognize that you have primary health care, secondary, and tertiary. So the tertiary, really, you have the consultant, the specialist there. That is their area because it's training, it's research, and it's service. But the secondary, the primary and the secondary area is where we need to train more people, the nurses and other providers, so that's so that the service can reach those areas. But it has to do with policy and awareness and the will to train. And the one thing I always tell people is work-based training is very important. If you take someone from a rural area to the city, the person will not go back. So the best thing is scale up the services there, scale up the theaters there, invite people to come. Because if someone came from Canada to Nigeria to scale up services at the Lagos University Teaching Hospital, others came from Britain to Ibadan, University College Hospital, to scale up the services there, then it follows that if we do the same thing in the rural areas, get someone to go down there, scale up and say, this is the red line, this is how you sterile area, this is what you do, this is how to use this machine, and then develop the workforce there, then things will improve. And I was talking earlier to Dr. Edna, and she mentioned something saying that they have a contract, they withhold they train them, and then when they go back to their local areas, within 2 years, they don't give them the certificate until 2 years. And within that 2 years, they're settled. So there are different ways of making people stay back by reaching out, scaling up, because what do we want? We want all the infrastructure, we want things to work out, give it to them, train them there, and let them own it.
So let's pull it back into the community before we end. I want to keep to time, and I don't know who's keeping time on us. Are we all right? We're good? Okay. In the United States, we have more or less a preventive healthcare model, and women overwhelmingly make the healthcare decisions for the whole family. So it creates a bit of an incentive for industry and the healthcare system to cater to women, because if they get good care for obstetrics and for gynecology before they become pregnant, they typically then will continue to bring their whole family into that healthcare institution system. But what is the situation in Nigeria? Is that happening at all? Or who controls healthcare decision-making in general in Nigeria?
It's multifactorial. It's different. From the north and the south, it's different. And it's based on the level of education and culture. Africa is a multicultural area. So the more educated the woman is, or women are, the more they seek medical care, while the ones who are not educated do not seek care. And then because they don't have jobs or it means a livelihood, they take it. We have a lot of very complicated cases, because you see there's a small mass, you don't go check it up, it becomes cancerous. Little things like that. Or, so it depends on the area, the level of education. Now, in the northern part, culturally, you're not meant to cry. A woman is in pains, and you have to hold it until there's sepsis or there's something huge. So it's really different. Whereas in the western part of Nigeria, there's nothing wrong with you, but you're shouting, you're screaming. So it's really different. And what we need to do is understand what the culture is, and then educate, train, encourage women to speak out, because they stay at home with the children, with the family, and like you said, the more we can encourage them to have a voice, to speak out, to say this is not right, then there will be better use to the population,
Well, on that, I think we'll end. I want to thank you so much for joining me here today. Thank you.